happy to introduce our next speaker who will join us online. It is Professor Amedeo Azizi. He is a pediatrician and a neuro-oncologist and the head of the Austrian Center of Expertise for Neurofibromatosis at the Medical University Clinic of Vienna. He's also the coordinator of the Austrian NF network, a member of the ERN Centuris, co-author of the ERN Guidelines for Tumor Surveillance, and author of the Austrian Care Guidelines for NF1 patients. He has a particular interest in low-grade gliomas, and he will talk about how clinical management changed of plexiform neurofibromas changed since the introduction of MEK inhibitors. Welcome, Professor Azizi. I hand over to you. The floor is yours.
So thank you so much for the invitation and greetings to all the members of NF Patients United that are present today, and to the other speakers, so my sincere regards. And I'm happy to talk a bit about the management of plexiform neurofibroma and how this has changed in the era of MEK inhibitors that are now approved for the treatment. So these are my disclosures. To the background, plexiform neurofibromas occur in around 30 to 50% of patients, regarding whether or not you use whole body MRI. They may be present already at birth. They are pasty, soft masses, sometimes with embedded harder nodules. Often they are hyperpigmented, sometimes with hypertrichosis. What does that mean? There are many hairs on top of the lesion. It might have an itching or burning sensation, or there might be dysesthesia. What does that mean? That means an altered feeling, like tingling sensation or whatever. Sometimes they may be disfiguring, and sometimes they may be mechanically disabling regarding on the spot on where they are located. So these are just some images of large plexiform neurofibromas and the respective MRI images to that. So if we talk about plexiform neurofibroma, we have to discern the location, the size, and the severity, which vary greatly between single patients. As I said before, progressive plexiform neurofibromas may cause extreme disfigurement, and it has to be mentioned that one of the first facial transplantations that have ever been done were done in patients with neurofibromatosis type 1. They might be very disabling and interfere greatly with the regular growth function of the region. It might come to overgrowth, for example, of an extremity, of an arm or leg. But it might also be that pain occurs because these neurofibromas result, as Professor Legius just showed nicely, result from nervous lesions. So they might exert stress on the nerve, like pulling or pressure. This might lead to weakness, numbness. Sometimes, because these tumors are highly vascularized, it might lead to bleeding. There might be bladder or bowel habit changes, and it might be life-threatening if the airways are obstructed, for example. But we also face the possibility of malignant transformation, as was shown previously in the previous talk. So the risk of malignant transformation is around 10 to 15% from plexiform neurofibroma to malignant peripheral nerve sheath tumors. And what are the red flags? So what are the symptoms that the patient should be educated to look for? Rapid growth of nodules, novel or persisting pain, and change of neurological symptoms. So, for example, if a paralysis occurs or if there's any change in neurology. So the highest prevalence of MPNST is in the age between 15 and 40, but they may occur at any age. The youngest patient I've seen was 9 years old. In literature, there are patients as young as 1 year of age. The median age is 26, so this is really quite young. So meaning that half of all patients had already had their MPNST at the age of 26 for those that where the tumors occur. So there are high recurrence rates, rapid disease progression, and poor prognosis, and there's a high potential of metastases and early metastases in MPNST. So this is something that has already been shown about this progression also of the genetic profile of these tumors coming from loss of neurofibromas NF1 in the cutaneous neurofibromas, in the plexiform neurofibromas, and then there is added CDKN2A loss, and then there are other like PRC2 loss or SARS12 loss that occur later on. And so it's very important to discern the first signs of malignant transformation in order to remove those tumors before they turn malignant, just as Professor Legis just said before. If you look at the natural history of plexiform neurofibroma, you see that they might show growth over time, but it's very variable in each patient. And you could see that some of these tumors were even shrinking, but never more than 20%. And around 3/4 had an increase in volume of more than 20% of an observation period of median 7 years. And around half of those patients showed even more than 20% change per year. And what is very important is that younger kids have a higher rate of change and increase of tumors than older patients. And this is what is shown here. So this is the age of the patient and the change in volume. And you can see here, the younger the patients, the higher the volume change. Coming to the management of plexiform neurofibroma, it's very important. This is the key message of the whole talk, actually. This has to be done in specialized NF1 centers that can take care of those patients with complex neurofibromatosis cases and do that in an interdisciplinary fashion. So that means that you have to bring the surgeons, the radiologists, the nuclear medicine specialists, the oncologists, the nephrologists, all on the same table to discuss a case. And this is the most important thing. So in our center in Vienna, we have a close cooperation in our center with the different partners, but also around around Europe and overseas. So if you have really difficult cases, sometimes even if you're a specialized center, you need to approach another specialized centers that might give you a further input. So this is what I've already talked about, who is part of that nerve sheet tumor board that we are organizing at our center. And we do that actually as a virtual tumor board so that other centers can present their cases to our board. We have the NF specialist, the pediatric oncologist, adult oncologist, neurologist, plastic surgery, who does the nerve surgery in our department. Sometimes it's the neurosurgeons that do it in other departments. Radiologists, nuclear medicine specialists. I was talking about neurosurgery already. And depending on the localization of the tumor, you might need some other specialists like pancreas surgeons or ENT surgeons. So the most important thing in the management of NF1 is nihil nocere. What does that mean? Do not harm. So most manifestations are benign, and there's a fine line between too much therapy and treating all too late. So the question that remains is when to treat and when to observe. So when is therapy indicated or even reasonable? And the question also remains, is growth arrest a success or just a natural course of disease? And it's all about quality of life. We are talking about benign tumors here. So the surgical removal or reduction still represents the gold standard for treatment of neurofibromas, because a tumor that has been removed is gone. So you don't have to treat them over years and years with medical treatment, for example. However, and this is important, some neurofibromas are difficult to treat by surgery because of the size of the tumor, the localization, or infiltration into surrounding tissues. So I've been talking about that before, but this is so important. That's why I'm repeating it here. When do we have to do surgery? If there are signs of transformation, to secure histology, if there's rapid growth of nodules, newly occurring or persistent pain, new neurologic complaints. We also defined that if there is a change of texture, meaning that if a hard nodule appears actually in a rather soft neurofibroma, this also might be a sign of transformation. We can do imaging with FDG PET if we have clinical signs that let us think of malignancy, or we can do it as a screening tool in patients with very extensive plexiform neurofibroma or whole gene deletions, for example, with flanking regions, including SAS12 gene region. So we can find malignant transforming lesions. So when else to do surgery? If there's physical irritation or obstruction, if there is compressions of organs, friction, inflammation, and lastly, for cosmetical reasons, which might be the leading cause actually for the patient to look for the surgeon. So surgery has only to be done by experienced surgeons with practice in nerve surgery because of the risk. What are the risks? Nerve damage, blood loss, because these are highly vascularized, and wound and skin closure, because the skin on top of a plexiform lesion is not to be considered as normal skin. So this means that there might be wound healing problems afterwards. So, and there are many factors that come into play, but we don't yet know what are the risk factors for postoperative progression. So we have looked at various factors, but none of them was actually identified. Coming to non-surgical therapy, we have to go back to the molecular basis of NF1. So I always compare that to a light bulb that is turned on and turned off. And this is the same with actually this MAP kinase pathway, where there is RAS that has to be activated, then leads down a whole pathway that finally leads to gene expression and cell growth. So if the light bulb is turned on, a growth factor will activate this whole pathway. There is a little side pathway that is activated then too, but we mainly focus on that pathway here. And neurofibromin, what does that do? It actually deactivates RAS GTP to RAS GDP and turns off the light bulb. So if neurofibromin is deficient or not working, then this whole pathway is being overactivated because the switch is actually defective. What does now the new MEK inhibitor do? You see that there's RAF-MEK-ERK. It actually does inhibit downstream of this whole switch, so it kind of breaks the line, and therefore the light bulb is not turned on anymore. Now there was done a trial for selumetinib, which is one of the MEK inhibitors that is on the market. This was first a phase 1 study where they could show that with increasing doses and doing MRI tumor volumetry afterwards, they could see reduction of tumor volume in all patients and a reduction of tumor volume by more than 20% in around 71% of patients. And this was the first drug that actually showed to be effective in plexiform neurofibroma of NF1. But the most common side effects, and these are side effects that we commonly see in many tyrosine kinase inhibitors, which the MEK inhibitors are a part of, acne, pharmac rash, gastrointestinal effects, and creatine kinase increase. This is just a blood value that normally does not become symptomatic, but this is a muscle value. If you look at the natural history study, which is the blue line here, compared to the selumetinib treated patients, you could see there was a great difference between those two lines, and the progression-free survival was 84% after 3 years. What you could also see is that in some patients, you could see a really steep decline in tumor volume, which showed nice results. So there was then a next follow-up study that led finally to the approval of selumetinib in patients with plexiform neurofibroma, where you could see that in 2/3 of patients, a tumor volume decrease of more than 20% was achieved. You can see here, we call that a waterfall plot. You see, this is the line of minus 20%, and these are all the tumors that were regressing more than 20%. And the reduction in volume average was around 28%, which has to be very clear to the patient actually that those tumors will not vanish. they will decrease, and the maximum decrease was around half the size, so or half the volume actually, to be honest. So this has to be clear to the patients that we are not talking about a drug that will completely get rid of the plexiform neurofibroma. So this was a comparison to the natural history curve I was showing before. And you could also see improvement of symptoms like reduction of pain and other symptoms and improvement of quality of life. But if you look at the long-term data, and so these are the data given here. You had the cutoff at 3 years. It was the first curve that I was showing to you. You can see that actually even in those patients who have been treated on selumetinib, you see that you just shift the curve to the right, but you do not completely abolish further growth of the tumors. So this is something we have to keep in mind now that we know a bit more about those treatments. So it was the PFS, the progression-free survival, was 50% at 7 years. So the 50% threshold was reached at 7 years. In the natural history study, it was around after 1.3 years. So the possible side effects, also these have been studied more in detail. Most commonly rash in around more than 70% of patients. This is just really a lot, okay? Diarrhea, loss of appetite, nausea, fatigue, those CK elevations in lab that we could see, paronychia in around 40%, especially in children, which is very worrisome actually to continue treatment in full dose at least. Retinal detachment, this is a rare event, but an event that we have already encountered in our center. Left ventricular dysfunction is also very rare. It's much more common in adults than it is actually in children, but also we had now our first patient where we could see that. So what are the long-term effects? What is about fertility? We need a selumetinib post-marketing study that is on the way and that will close in May 2025. So we will get those results hopefully in a short time. What is important to know is that this is a class-wide effect. There are other MEK inhibitors on the corner, like trametinib that has been used a lot, or cobimetinib. And now there is the ReNeu trial, which was a pivotal trial to use mirdametinib, which is just another MEK inhibitor in patients that were adults and children. So this is something that's important because selumetinib was only approved for children. The approval for adults is on its way and the approval will come very soon, apparently also for adults. But this trial for mirdametinib led to approval of mirdametinib for adults and children in the US. It is not on the market in Europe yet. So talking about this, these included half adults and half children with NF1 that caused morbidities. And very importantly, and in difference to selumetinib, there is an oral suspension. So you can treat very young children that cannot swallow capsules. There was a 3-week on, 1 week off, and you could see that you could reach objective response rates in around 41% in adults and 52% in children. You usually see more response rates in children than in adults. The same holds true for selumetinib. You could reduce pain, have better quality of life. So it's pretty much comparable to the results that we've seen in the selumetinib trial. The side effects are pretty much the same as we would have expected. So these are the waterfall plots of that study. I won't go into detail. Same with the comparison to the NF1 natural history study. We will see what happens with that curve later on. We don't know that yet. So there is selumetinib that is marketed, mirdametinib that is only marketed in the US. And there are other MEK inhibitors. We, for example, sometimes have to use trametinib because there is an oral formulation for kids, meaning a fluid formulation that even younger kids can swallow. So what questions do remain? When and how should we stop treatment? Because we know that there is a high rate of recurrence after stopping. What happens after discontinuation? How often do relapses recur? occur, I'm sorry. Do patients respond again after relapsing? So far, we think yes. In case of progression, should we switch to another MEK inhibitor? Would that change anything? Or is it just a class-wide effect and wouldn't change anything? Just shortly, other approaches. There has been a study by Mike Fisher on cabozantinib for neurofibromatosis type 1 related plexiform neurofibromas in adolescents and adults. This is a pan-kinase inhibitor. And you could see that around half of patients did see some partial response, around 42%, and the side effects were those of a TKI, of a tyrosine kinase inhibitor, so there are some options that are on the corner, but yeah, we don't know that other yet. What's about radiation therapy? Radiation therapy for plexiform neurofibromas has to be avoided because there's a risk of secondary tumors like high-grade glioma or MPNST if the brain is irradiated. Vascular complications like moyamoya or stroke. Once again, if the brain is irradiated, there might be neuropsychological or endocrine problems, especially only if the brain is irradiated. So there is the radiation therapy should be reserved for highly malignant tumors like malignant peripheral nerve sheath tumors, where prognosis is very poor and you have to treat that one tumor and not worry that much about the tumors to come. In conclusion, the management of NF1 plexiform neurofibroma is multidisciplinary, and you have to balance the possibility of observation versus treatment. And treatment options include surgery, drug treatment with selumetinib, and nowadays, but not in Europe yet, mirdametinib. And I'm coming to the end of my talk, and I say thank you so much for your attention, and I think I'll stop sharing now.